Welcome to Gene-ius Medical Education. This is going to be the first video in a series I am calling Pitfalls of NMBE, where we will cover various topics that are historically confused by students when taking medical standardized tests. I don't want to give the topic away yet because I'm going to give you a practice question on the next slide, but where will we see this topic? Pre-clerkship endocrinology, IM shelf and clerkship, any endocrinology electives that you do, and on step 1 and step 2. All right, let's jump into our first question. A woman has a plasma osmolarity of 300, which is on the high side of normal, and a urine osmolarity of 1200, which is high. The correct diagnosis is A, SIADH, B, water deprivation, C, central DI, D, nephrogenic DI, or E, drinking large volumes of distilled water. These 5 conditions, each of which affect osmolarity in some way, are very commonly tested together on NMBE exams. This is why I always recommend skimming the answer choices prior to reading the question stem. Because once you have recognized that you have a question that is asking you to choose between these conditions, I want you to think back to this video and systematically approach the question stem in the following way, which we will cover to ensure that you answer the question right every single time. Let's just set some groundwork to make sure we're all on the same page when approaching these questions. So what is osmolarity? For our purposes, we just need to understand it's the measure of concentration of dissolved substances within a fluid. Okay, so we look at serum osmolarity and urine osmolarity. So in serum, our fluid is blood, and in urine, our fluid is urine. The substances that make up each of these osmolarity are slightly different, but we see that sodium is a major proportion of each of these. And actually, when we look at serum, we can use serum sodium to give us a good idea of what the serum osmolarity is. Once we determine we have an osmolarity question, what we're going to do is look at serum osmolarity or serum sodium. If it is high, then we know that we are dealing with either central DI, nephrogenic DI, or dehydration. So all the ones that start with D. If it is low, we know we are either dealing with SIADH or primary polydipsia. Once we have determined our serum osmolarity, our next step is going to be looking at urine osmolarity. And once again, we're going to see if it's high or low. If it's high, we know we're either dealing with SIADH or dehydration. And if it is low, we know we are dealing with central DI, nephrogenic DI, or primary polydipsia. All right, so let's summarize this. So in syndrome of inappropriate, aka too much, anti-diuretic hormone, we have too much anti-diuretic hormone. What does that mean? Our urine is too concentrated. So we have an increase in urine osmolarity and a decrease in serum osmolarity. We then have the opposite issue in DI. There is an issue with too little ADH or not responding to ADH. So we have an increase in serum osmolarity and a decrease in urine osmolarity because we cannot concentrate our urine. Notice how the 3 conditions that involve an issue with ADH have opposite serum and urine osmolarity. That is in comparison to primary polydipsia and dehydration that have to do with water intake. Those have the same either increased or decreased in both serum and urine osmolarity. So in primary polydipsia, when someone is drinking too much water, there's a decrease in both serum and urine. And in dehydration, where someone is not drinking enough water, there's an increase in serum and urine osmolarity. You can use just these 2 values, serum and urine osmolarity, to differentiate all these conditions except for 2. You'll notice that they're the exact same for central DI and nephrogenic DI. So if you notice that you have an increase in serum osmolarity and a decrease in urine osmolarity, there's one final step that we need to do to figure out the right answer. There's 2 major ways that you can differentiate between the 2. The first is history. So look in the question stem to see if they give any hint to if this is central or nephrogenic DI. If it is central, they'll give some hint of brain damage. This could either be from a tumor, infection in the central nervous system, traumatic brain injury. There's others, but there's going to be signs of brain damage. And in nephrogenic DI, there's many different medications that can cause this, but the major one that is tested is lithium. So if the person has a history of bipolar disorder, or they actually mention lithium usage over long periods of time. Or they may give you nothing to help you differentiate from the history between central or nephrogenic DI. In that case, we're going to be looking for a vasopressin challenge, which will correct the osmolarity in central DI, but not correct the osmolarity in nephrogenic DI. So vasopressin challenge is effectively providing the body with ADH. So we already talked about how in diabetes insipidus, you either lack ADH, which is the case in central DI, or you lack the receptors to respond to ADH, which is the case in nephrogenic DI. So if we give the body ADH to work with, we will see correction in central DI because the receptors for ADH on the kidney now have their substance to trigger the body to be able to concentrate urine. However, in nephrogenic DI, adding more ADH to the body is not going to cause that same reaction because you don't have the receptor to bind to, and therefore you cannot concentrate your urine. Something that test takers struggle with is understanding if they are dealing with like a high or a low osmolarity. For serum, not so much because the range is pretty tight. It's normal would be from 275 to 295. But urine osmolarity is somewhere, normal would be between 500 to 850. But sometimes they have even much wider ranges on these exams on the lab values that are provided. And the trick here is to compare the two. So if you have one osmolarity, say serum osmolarity, that's on the high side of normal or just really high, and then you have your urine osmolarity, is it on the high side of normal, low side of normal, or is it completely out of the range? Look at that. So are they, moving towards the same side, the high side? Are they moving towards the same side, the low side? Or are they really on opposite sides of the ranges? And that can give you an idea too. Now let's go back to our question. I look at these answer choices and I immediately know I'm dealing with an osmolarity question. So the first thing I want to do is look at the serum osmolarity. I'm going to use orange to denote that. And then I want to look at the urine osmolarity, and I'm going to use blue for urine. Okay, so first looking at serum osmolarity, I know that my patient is on the high side of normal. SiADH, I know it's going to be low, so that can't be the right answer. Water deprivation, that is high, could be that. Could be either of the diabetes insipidus. And it can't be drinking large volumes of distilled water because that will also have a low serum osmolarity. Okay, final step. Let's look at the urine osmolarity. We are looking on the high side of normal. And honestly, I probably wouldn't even have to run through these because I already know, these are both on the high side. I'm dealing with one of our water intake problems. However, let's think about it. We're left with water deprivation, central DI, and nephrogenic DI. We know that water deprivation will have high urine osmolarity, but central and nephrogenic DI will have low urine osmolarity. Therefore, the right answer is B, water deprivation. All right, and that was pitfall number 1 when it comes to NBME examinations, conditions that affect osmolarity. I hope that this was helpful, that you'll be able to recognize this pattern of question in the future, and that you now have the tools to always answer these questions correctly. Please don't forget to like, comment, and subscribe to Gene-ius Med Ed for more help on the NBME exams.